Great. Thank you so much for having me here today. I will be discussing dermatomyositis in 2026, mechanism-driven therapy and emerging phase 3 evidence. These are my objectives for this talk today. First, I will be reviewing some early proof of concept studies of JAK inhibition in dermatomyositis. And then I will delve into highlighting the key findings of a recently published and completed phase 3 trial of brepocitinib in dermatomyositis. And then lastly, I will then contextualize these findings in relation to earlier studies and clinical practice. These are my disclosures. So I don't think I need to tell this audience about the heterogeneity of the clinical presentation in idiopathic inflammatory myopathies. It can be quite challenging, but also very rewarding because our patients can present with so many organ manifestations, including obviously the skeletal muscles and the skin, but also interstitial lung disease with pneumomyositis, for example, with MDA5 dermatomyositis and cardiac involvement, which can be quite challenging, especially with myocarditis to treat. But despite this heterogeneity, I would say the myositis community has tried to gain some clarity by dividing patients with myositis into different subgroups. And I think in the past 10 to 15 years, we really appreciated there were four main subtypes of myositis, including dermatomyositis, immune-mediated necrotizing myopathy, inclusion body myositis, and of course, polymyositis, which is really a diagnosis of exclusion. But I would say in the past 3 to 5 years, there's been a greater understanding that there may be even more nuanced, distinct subgroups of myositis. And those are anti-synthetase syndrome. And there's been an international collaboration through this classification project that really anti-synthetase is unique and a distinct entity. And lastly, I think we are going to be hearing more about overlap myositis because these patients have been conventionally ignored in clinical trials and always excluded. And I do think there will be some changes in the next 5 to 10 years about really including these patients and also understanding and classifying them better. Now, moving on to treatment paradigm of myositis, I think I probably did discuss this a couple of years back, but I wanted to bring this slide back and say, we're still kind of in this old era of using steroids and using one of these agents. And this is largely based on uncontrolled trials and case series. And how do we decide? It's usually based on expert opinion and what we have available for our patients. But it is also, of course, as a rheumatologist, we're trying to finely clinical phenotype our patients and determine whether a patient has more joint involvement with their skin and muscle disease, in particular for dermatomyositis, versus and use methotrexate in that case. Or if they have more lung involvement, we tend to reach for azathioprine or mycophenolate. And of course, we have looked at our Johns Hopkins myositis registry in conjunction with our leading expert, Dr. Sonia Danoff, in the ILD, Interstitial Lung Disease Center, where we try to look retrospectively and see if is azathioprine or mycophenolate more effective, which one is more efficacious, and it looks pretty much the same. And I think this is why we don't have any head-to-head studies, but maybe in the future we can actually do more large-scale studies that can look at this using cohort registries data. But as I was saying, the reason I'm bringing this slide up again is because this is a paradigm that has been perpetuated over many, many years, as you can see, since the 1990s, since we started treating myositis patients. And it's always been this empiric step-up therapy. We'll start with one of these DMARDs, and then we usually add one of these other agents, depending on if they have dysphagia or if they have rheumatoid arthritis, in conjunction with myositis, we, use rituximab. But I think the field is really changing. And one classic example is in dermatomyositis. I think in the past, 10 to 15 years and more, the first publication about the importance of type 1 interferons was in the 1990s. And similar to lupus patients, we know that patients with dermatomyositis can have really high type 1 interferon signature in the blood, in the muscle tissue. And I'm going to highlight some of that in our proof of concept trial briefly and then delve into the phase 3 data. But knowing that the type 1 interferon pathway is so important in dermatomyositis, it was not a surprise that there was a publication out of Germany back in 2014 where they reported an accidental use of Jakafi or ruxolitinib. Um, in the US, it's called Jakafi, but I'm not really sure here in Pakistan. But it was used to treat a dermatomyositis patient. And of course, there was this controversy that you're treating the myelofibrosis, and this patient was an accidental discovery that the patient's dermatomyositis improved, and so there was controversy whether this was really mechanistically made sense to use a JAK inhibitor in dermatomyositis. But I do think the authors, Dr. Hormug here, initially really reported back in correspondence saying that it really did mechanistically make sense to use a JAK inhibitor because it does block the downstream pathways of type 1 interferon. So after that case report was published, around the same time, there was also a case series of patients from Brigham and Women's by Dr. Ruth Ann Voigels, a leading dermatologist who studies autoimmune skin diseases, about using tofacitinib for refractory cutaneous dermatomyositis. And since then, obviously, we also had a case report, one of the first case reports from our center where I had a patient where we used tofacitinib for refractory dermatomyositis, where not only their skin disease improved, but also their muscle disease improved on quantitative strength testing. So these were the initial case reports and early clinical observations supporting JAK inhibition. And that really led to a collaborative clinical trial from Hopkins, where I was the PI or the principal investigator, to design a trial that will ask the question of whether inhibiting this interferon JAK signaling, because we know interferon is a key driver of disease activity in refractory dermatomyositis, and questioning whether tofacitinib will reduce the skin and muscle weakness in our patients with refractory dermatomyositis. So I named the study of tofacitinib in refractory dermatomyositis, and this was the first proof of concept clinical trial as an open label study of 10 patients, where we were able to actually have all the patients completely wash out of all their agents, including IVIG, methotrexate, azathioprine, mycophenolate. They had to be off of everything. And they were given monotherapy with tofacitinib 11 milligrams XR daily. And based on what I had read in the RA literature when tofacitinib came out and was FDA approved in 2012, we decided to use week 12 as the primary endpoint. And this was important because you will see that this also led the foundation for deciding when the phase 3 trial of when to start the steroid taper. But I will discuss that a little bit later. But I think these first early proof of concept trials can, yes, of course, we would like to see efficacy, but it can really open up the field in a sense that if you have the clean mechanistic data to show whether the disease medication the medication that you're trying to use works or doesn't work, it really gives us that foundation needed to move forward to either a phase 2 or phase 3 trial with much more confidence than just blindly choosing a drug. And so I think this was the case, and I was very grateful that back in 2015-16, when I wrote this protocol, was able to incorporate, skin biopsies, needle muscle biopsies, muscle MRI, and also research blood, and also included a mandatory steroid taper to really assess the true effects of monotherapy with tofacitinib. So the primary outcome measure we used was this 2016 ACR EULAR myositis response criteria as measured by the total improvement score, or the TIS. The weighted score is from 0 to 100. And you can see there's these 6 clinical domains, including the physician global, patient global, manual muscle testing, the health assessment questionnaire disability, index, muscle enzymes, and the extramuscular activity or disease activity score. And minimal improvement is 20, moderate is 40, and major is 60. So what you're going to see here in this proof of concept study that was published in 2021 was that you can see that there was at least out of all the 10 patients who received the drug, which there were only 10 patients, the median total improvement score was at least 40 in all these patients, which is, significant in a sense that the patients did have more than a minimum improvement. And also, one of the striking observations that you also see duplicated in the phase 3 trial was that these patients responded very quickly at week 4. The biggest limitation, however, of this proof of concept trial is that there was no placebo group. And I think this is a big limitation. But, a picture is worth 1,000 words. And you can see clearly, like, you cannot hide the skin improvement. And this patient's baseline skin score, the CDASI, which is the cutaneous dermatomyositis activity and severity index, where the skin is scored by how red it is and how flaky it is. This patient's score at baseline was around 57, and at week 12 was almost completely resolved, except just a little bit left in the posterior neck. And the V-neck sign you can see significantly improved by week 12 as well. And in terms of the additional mechanistic data that provided more robust evidence that this pathway can be actually very beneficial in targeting was using the skin biopsies and showing that STAT1 was definitely upregulated in these two patients, as you can see here. This is the first patient, and the second row is the second patient, where this is very highly upregulated, STAT1. And then by week 12, with monotherapy with tofacitinib, it was significantly diminished. We also looked at chemokines to better understand downstream regulators of type 1 interferon and type 2 interferon. And we not only looked at CXCL10, but also CXCL9, which was surprising because I had actually hypothesized that more CXCL10 would be downregulated because that is primarily driven by type 1. But CXCL9 was also downregulated, as you can see with the two asterisks here, was also statistically significant. And this is primarily induced by type 2 interferons, highlighting that maybe these refractory patients, both type 1 and type 2, are upregulated. And these are why these patients don't respond to more traditional medications. In addition to gathering chemokine data, we were able to do muscle MRIs, and you can see that pre and post treatment, there was improvement, but this is qualitative, and there could be some limitation because I may have to convince you that there was edema here, and then this improved, and the subcutaneous edema was here, and it also improved in the posterior muscles with the muscle edema. And so this is why I will show you a little here, this slide, that we took a bit of a deeper dive, and this is just recently accepted for publication in ACR Open. It's in press, but we also took a deeper dive and wanted to quantitatively show improvement using diffusion weighted images. And fortunately, gratefully, that when I designed the trial, I wanted to capture quantitative improvement because of my given long-standing interest in muscle MRI. And so we were able to go back and actually quantify these scores with diffusion weighted images and show that here, this is the STIR image, and there's improvement here in the muscle edema, as you can see in the posterior compartment. And then we were able to quantify looking at diffusion weighted image and doing a ROI, that this improvement was quantifiable and also correlated with improvement in muscle strength. Now, going back a couple slides, in addition to the muscle MRI, we wanted to understand mechanistically if type 1 interferon signature was down-regulated. And you can see here clearly there was a 40-fold down-regulation or inhibition of type 1 interferon log-fold change. And also for type 2 was greater than 30, about 35. And this is highlighting again corroborating what I showed you with the STAT1 downregulation. The skin biopsies are also showing type 1 interferon downregulation, and the muscle was also showing type 1 downregulation as well. And we were able to also incorporate a interferon score looking at all the gene signatures of interest in the muscle. And you can see here in this volcano plot, you see IFI 27, MX2, ISG 15, which are very classically um, uh, upregulated in dermatomyositis patients in the skin, but also in the muscle. And so we were able to calculate the score. And we a priori said if the score was greater than or equal to 1 of a log fold change, that was significant. That was statistically significant. And we even took it further and said if it's greater than 2, it's significant. Obviously, the log fold change, and it was a statistically significant. But as you can see here, the average interferon score change was about a 6. So it was definitely, even though a lot of these patients had more refractory skin disease, the target organ of the muscle that we all see as rheumatologists was definitely downregulated after treating with tofacitinib, highlighting that it can exert its therapeutic effects in the muscle. All right. So that's kind of the foundation of how JAKs were starting to be used in a very well designed, I would say, proof of concept trial. And of course, we were very excited to see this. We're very lucky to see this kind of efficacy results. And this is why we also did a long-term extension to see safety and also efficacy. And we went out to week 96. And you can see for sure the skin, there was definitely continued improvement with people tolerating the medication. And that is why, actually, when the pandemic happened, very lucky that once the trial was completed, it was like the last patient, last visit was at the time of the pandemic when it started. So it was good because everything was shut down at Hopkins, and I'm sure it was also the same in Pakistan, unfortunately, with the pandemic happening. And so during this time, we were trying to understand whether JAK inhibitors, what is the international use of JAK inhibitors? What is already published since the completion of our clinical trial, of the proof of concept clinical trial? And what we did was we did a systematic review, and you can see the total records was about 749, and we reviewed 313 unique records. And we actually took that December 2014 as the start point when that ruxolitinib was used in dermatomyositis as that initial case report, and out to August 2021. And you can see there was 84 unique adult patients and 34 publications in adult dermatomyositis. And there were also in JDM, you can see there were about 15 unique publications as well. So certainly there's a lot of use of JAK inhibitors in JDM. But bottom line, what did this systematic review tell us? It told us that there was a lot of overwhelming evidence that cutaneous disease, there was no doubt that there were many publications, and all patients had improvement, and the skin disease tended to improve between 4 and 12 weeks of treatment, versus muscle disease, there was significantly less, almost half, 14 publications, and only 16 patients where there was some improvement in the muscle. And I think that was the biggest question for me, and it was a question I received a lot, was in the adult dermatomyositis patients, the initial study that we completed of 10 patients, I only had 2 patients who had significant muscle weakness, right? And so the question was, yes, I know it works in the skin. There was no question. And you can see that there was a lot of publications supporting that as well. But for muscle disease, I couldn't confidently say, even based on our, proof of concept trial, that everyone or a majority of the patients were going to improve. And so when a small biotech company had approached me about trying to do a bigger study, either a phase 2 or phase 3 trial in dermatomyositis, I was very excited, but I wasn't 100% sure if it was going to work in the muscle, but I was excited because there was a, biotech company who was very interested in targeting patients with rare diseases and also a strong unmet need, and trying to do a bigger trial. And so that drug was brepocitinib at the time when I was approached by them. And I would have to say, I didn't know that much about brepocitinib, but what we knew at the time, in discussing with this biotech company, a Priovant, was that it had already been used in psoriasis with some degree of success, but Pfizer was not going to move forward with using brepocitinib in further development. And so this company decided to go in together, 50-50 with Pfizer and Priovant, and try to look at drug diseases where this drug can actually be very helpful for patients. And so obviously one of the diseases that have a high unmet need at the time during this pandemic when I started to talk to this company was actually dermatomyositis because we know type 1 interferons are much, as I told you, as I discussed, was highly upregulated in these patients. And so we're excited that, that they actually decided by listening to all of the KOLs in the US, including myself, and also internationally everywhere, that this could really be potentially a drug that can work in dermatomyositis. And so this drug is a first-in-class oral selective TYK2 JAK1 inhibitor. And as you can see here, it's an inhibitor of the catalytic domains of TYK2 and JAK1. This dual TYK2 JAK1 inhibition, when I remember talking to them, during the pandemic about this drug, was that it uniquely targets both type 1 and type 2 interferons. And it can also, target IL-6 and IL-10, IL-12, and IL-23. And there are some benefits because in contrast to the non-selective JAK inhibitors like tofacitinib and baricitinib, there's no kind of undesirable effects on the JAK2 and 3 pathways like hematologic side effects. And it is it is thought to be a bit better than JAK1, pure JAK1 inhibition because there's no impact on TYK2 and you're not going to be getting as much type 2 interferon down suppression. And so based on this, we designed a protocol that actually would target a large population of patients with dermatomyositis and try to capture those patients who have real world clinical disease. And so what that trial at the time was when we designed it, and I have to say, I do have to give some kudos to the company because of the fact that they really listened to all the KOLs, key opinion leaders, to design the best trial for our patients with dermatomyositis. So what did this trial entail? The eligible patients were definite or probable dermatomyositis. They had to have at least minimal skin disease activity. Remember, 5 or less is remission. So anybody with minimal skin or higher was greater than or equal to 6. Muscle disease activity had to be less than or equal to 142, meaning they needed to have at least mild weakness. And then they had to be refractory or intolerant to standard of care therapy. And the permitted background therapy was an oral immunosuppressant. For example, they had to be on methotrexate, azathioprine, mycophenolate, tacrolimus, and they could also be on a antimalarial like hydroxychloroquine and or oral corticosteroids. But they cannot be on like methotrexate and azathioprine together, not two oral immunosuppressants. And as you can see here, it was a tall order because the FDA actually said you have to do a 52-week treatment period, which is very different from the IVIG study, prodrome trial in dermatomyositis, where they allowed a 16-week study. So this was a tall order because trying to put patients in a trial for a year can be very challenging. But, we did it. And this 52-week study had 3 arms, so Brepo 30 milligrams, Brepo 15 milligrams, and placebo. And as I was telling you, there was a mandatory steroid taper that was enforced in the clinical trial. And it started at week 12 because, as I told you about our initial proof of concept study of tofacitinib in refractory dermatomyositis, that was the time point where we thought the drug at least started to work at week 12. And the taper was drawn out to week 36. And after that, the taper could be further enforced at the investigator's discretion. And the primary endpoint here again, time point was 52 weeks, 1 year. And the endpoint was again that total improvement score that I showed you where there's 6 domains that capture physician and patient global muscle enzymes, muscle strength, and disability index, the patient-reported outcome measure of health assessment questionnaire. So what did the Valor study enrollment look like? So it was a global study um, where I was one of the global leads, but you can see that there were multiple US sites, and about 40% were from US and Canada. And then there were European sites, as you can see here, including Hungary, Israel, Germany. And then in South America, Chile was also strongly represented, and Mexico. And there were two sites in Asia, including Taiwan and also South Korea. And I was going to say that there were 241 patients that were enrolled, which is quite large. And I'm sorry, 244. Um, so this is the baseline disease characteristics. As you can see here, the mean age was approximately 50, and the females were predominantly represented. And I already told you about the regional distribution. Duration of disease less than 3 years versus greater than or equal to 3 or more years. So I thought it was a good representation all across the board, across the 30 milligram group, which is the high dose, and then a 15 milligram group, and then placebo. There was also prior history of neoplasm. So you may say, of course, the patients who had, cancer-associated dermatomyositis were excluded. So if you had a cancer within 3 years, you were excluded. But if you did have squamous cell cancer of the skin, you were allowed within a year. And if you had thyroid cancer within a year, you were also allowed as long as that was treated and resolved. And then there was also, as I was saying, these are kind of, when we designed the study, we really wanted to include those who had, real world disease, as I would say it, like, cardiovascular disease. A lot of our patients have hypertension. So anybody with hypertension, obesity, coronary artery disease, as long as they didn't have angina for like 3 months prior to enrolling, they were allowed into the trial. So about 67% or 60% all across the board had more than one cardiovascular risk factor. There was also a history of ILD that was allowed, but you couldn't have severe ILD being on oxygen to enter the trial. So about 20% across the board had ILD on entry to the study. Now, for baseline disease and treatment characteristics, the muscle strength score, as you can see here, maximum is 150, meaning you have 5 out of 5 strength all across the board. But here, our patients had about 120, which means they had at least 4 minus out of 5 strength in multiple muscle groups. And the CDASI activity score is also out of 0 to 100. And you can see, remember, you could just have mild skin disease, but the average skin activity score was around 19.5, 18 to 21 across the board. And that means that they had at least moderate skin disease activity. And their disease disability index, as a patient-reported outcome measure, was 1.28 in these groups, 1.2. And this is indicative of at least mild to moderate disability. And this is a questionnaire that a patient fills out that captures like how much muscle pain do they have? Can they get out of a chair without, disability? There's multiple questions. It's like almost 7 domains of quality of life that they are answering these questions. So again, 0 to 1 is, no weakness. 1 to 2 is mild to moderate weakness, and 2 to 3 is severe, not weakness. 2 to 3 is severe disability. Okay. Now, the medications at baseline, most of the patients were on a non-steroidal immunosuppressant because that was required by the clinical trial. But of course, if you were not on it and you had active disease, you could enter it with just being on Plaquenil as well. Or if you had side effects, you could be on prednisone. And a oral immunosuppressant, as I was telling you, methotrexate, azathioprine, mycophenolate, or tacrolimus, but not combination therapy of the oral immunosuppressants. And the mean steroid dose was about 12.2, 10 to 12.2 across the board. And 2 or more DM medications means that they were on either an oral immunosuppressant and oral steroids or oral immunosuppressant with an anti-malarial plus steroids. And again, not more than 20 milligrams of prednisone was allowed at baseline when entering the Valor clinical trial. So about 20% across the board were also treated with IVIG, but clearly had a failure to IVIG, and they were entering the Valor clinical trial. So what is the patient disposition? As you can see here, 241 subjects were randomized, and the 30 milligram experienced the highest completion rate and lowest rescue rate. If you were rescued with steroids, um, then after the taper period, then you were considered as a non-responder. But as you can see here, 93% completed the blinded treatment period, and only 12 subjects, or 15%, received rescue medications. In stark contrast, you can see the placebo group, 82% completed the blinded treatment period, and 30% received rescue medication. And rescue medication is steroids or primarily steroids, higher dose of steroids, and also increased dose of their baseline immunosuppressants. Um, and I'm largely going to be talking about the Brepo 30 milligram group and comparing it to the placebo group. Um, and I will explain later, but there was some dose response. There was some response with the 15 milligram group as well. But the company is not moving forward for FDA approval with the 15 milligram because it was not as statistically significant by week 52. But as you can see here. So this is I would say, money slide, the key slide from the clinical trial that we were all involved in. And you can see here the top is a 46.5. And that means there's at least, moderate improvement. And this 37.5 was not statistically significant from the placebo group, and that's the 15 milligram arm. And this is why the 30 milligram arm is the one that's moving forward for FDA approval. But again, you can see that by week 4, it's a brisk response. These patients getting this drug had an early response at 4 weeks, similar to the proof of concept study trial that I led. The study of tofacitinib in refractory dermatomyositis. Here you're seeing that early response by week 4, and it's sustained durability out to week 52. And so it was very statistically significant. The change in the TIS was about 15.3, the delta, and that was statistically significant compared to the placebo group. And here is also a very important aspect of this trial. This mandatory steroid taper really allowed us to ascertain the direct effects of brepocitinib in these patients because they're not on background steroids, and they were able to taper the steroids. And look at this marked improvement of 62% were able to taper to less than 2.5 milligrams at month 12, and 42% were off steroids by month 12, which is more than double what you see in the placebo group, which was great. And I'd like to happily report that this was our clinical trial was accepted for publication in the New England Journal of Medicine on March 2026, March 28, just a few weeks ago. We're very excited to see that it was accepted for publication because it is very clinically meaningful for our patients to potentially have this new drug available for our patients. So that was the primary endpoint. The secondary endpoints, a priori, you can see, the CDASI, which is the skin assessment, the DMOMS. This is a new dermatomyositis outcome measure developed by Dr. Vicki Worth at University of Pennsylvania. And this is really trying to get at those patients who have a myopathic disease. And you'll see some future papers on this coming out of this trial, but this also met statistically significant results. And here, I'm not going to go through all of them, but all of the secondary endpoints and the primary endpoint met statistical significant results in the 30 milligram arm. So going back to that initial question of do JAK inhibitors work in the muscle? And unfortunately, I'm sorry that this did not come out properly, but this dark blue, it should be dark blue on the top. So the Brepo 30 milligram arm, definitely on the top here, you can see, definitely had improvement in muscle strength. And you can clearly see here that it started to show improvement in the muscle strength scores at around 18 weeks, and it was sustained out to 52 weeks. So it was great to see this data because it answered my question of whether JAK inhibitors, JAK in particular, maybe because this is JAK TYK inhibitor, works to improve muscle strength. Now, it is slower than, the skin disease, because as you can see here, for the skin disease, you're seeing it show improvement as early as 4 weeks. But I think that, physiologically makes sense because for skin, there's rapid turnover of the skin. You can see the results quickly versus muscle takes time to regenerate and the inflammation to go down. So I don't think it's a surprise that it will start to kick in a little bit later for the muscle disease. But look at this here. For the skin disease, the change from baseline in the activity score was at 4 weeks and sustained out to 52 weeks, and it was at least 11.7 point difference from the placebo group. And that change is statistically significant and clinically meaningful because there is data out in the literature to show that if there's at least a 5 point change in the CDASI activity score, that means that it improves quality of life tremendously in our patients with dermatomyositis. Similarly, disease clinical remission for cutaneous disease is a CDASI activity score of less than or equal to 5. And at week 52, you can see 44% were able to achieve that clinical remission by using the Brepo 30 milligram arm. And these are the representative pictures of the patients who showed improvement at week 12 and week 52. And you can see this posterior shawl sign improving gradually and almost completely resolved by week 52, similar with the V-neck sign. And there are also demonstration of the resolution of severe and ulcerative skin disease by week 52. And this, ulcerative disease at baseline in the elbows completely resolved here. And then in the face also completely resolved by the forehead also at week 52. Now, I think we want to always take it to another level in these clinical trials. And it was great to see when analyzing this data with the team that, the initial Proderm trial using IVIG in dermatomyositis that was published in the New England Journal in 2022, the FDA only required a TIS of 20, which is minimum improvement, right? There's TIS 20, total improvement score 20, then there's TIS 40, and then there's TIS 60. I think now we've really moved beyond this TIS 20, right? That minimum improvement, we can do better. And so the question was, did Brepo actually do better than a TIS of 20? And you can see with overwhelming evidence here that there was rapid and sustained achievement of moderate response of TIS greater than or equal to 40. About 68% were able to get to that TIS of 40, a moderate improvement at week 52. And it was seen as early as week 8 and sustained out to week 52. And then TIS 60, which is major response, this is a high bar. You can see about 43% were able to get to that by week 52 as well. What about taking it to another level from response to remission? So if we define achievement of low disease activity as a physician global of less than 4, patient global of less than 4, and being on steroids less than 5 milligrams, you can see here that by week 52, 53% were able to achieve that low disease activity score. And for clinical remission, we don't have a good definition, but we defined here as that is published, but we defined here for the purposes of this data analysis that it would be a physician global less than or equal to 1 and patient global less than or equal to 1 and steroids less than 2.5. So even a stricter definition of clinical remission, and more, about 24% were able to achieve that clinical remission, which is nearly 3-fold higher than placebo, which is, I think, great to see. So the summary of the safety data, as you can see here, because the biggest question was, fortunately, nobody died, which is great, because we don't want to see any deaths in any clinical trial. And the side effects you can see here, the serious adverse events were primarily infections and not surprisingly zoster, viral reactivation, but it was 5%, and you can see it was also seen with placebo, probably because they were on steroids, and their disease was not well controlled. But overall, the cardiovascular events and thromboembolic events were not very high at all, as you can see here. And it was more prevalent in the placebo group, highlighting that potentially, not controlling someone's disease is more concerning than putting on a patient worrying about their side effects. Now, I do want to be careful and say this is phase 3 data in very, uh, a very select group of patients with dermatomyositis, over a 52-week period. So I think we do need, over time, more data, like in a phase 4 data, to see if there are going to be any other more severe adverse events over time. Now, I think this is almost my second or third last slide, but I just wanted to highlight that I think we're really moving into a modern era of targeted therapy. And Valor represents a unique milestone, I think, because not only is it the largest dermatomyositis clinical study ever conducted, as you can see here. But of all these trials I have here, ravulizumab was a failed trial. Ustekinumab also. FCART is still ongoing, so hopefully we'll see the results of this. But this only had about 30 patients enrolled with a dermatomyositis. IVIG, I love IVIG. We use it all the time in our patients, but 95 patients. This is a 241 patients in this clinical trial. And I think this is highlighting a new era for our patients with dermatomyositis. So this is a summary slide of brepocitinib. It's a first positive 52-week placebo-controlled trial in dermatomyositis. And I know there's a lot of points here, but if I had to give you 3 points about this trial, the take-home messages is that brepo works quickly. Within 4 weeks, benefits were seen. It's durable, sustained out to 52 weeks, 1 year. And lastly, it's a targeted therapy that is directly exerting its therapeutic effects on type 1 interferon pathway. And so I think we're heading into this new era that we're not going to be just doing step-up therapy gradually, but we're going to use a drug that we know mechanistically makes sense in dermatomyositis patients. So this was an old review article that I did, not that old, but 3 years ago. I guess now it's getting older. So if I had to update this figure, I would say with this data, I would really use brepo early on. We have in addition to IVIG, we have a new drug that we can use that's oral once a day for refractory skin and muscle. And I think this is a very exciting time for all of our patients. So again, in conclusions, I hope I was able to impart to you that these early proof of concept mechanistic trials can be valuable signals for later phase 2-3 trials. And again, efficacy was quick at 4 weeks, durability out to 52 weeks, and skin and muscle both had improvement after treatment with brepocitinib and dermatomyositis. And the decision for the FDA approval, they did an expedited review, which is excellent because it's a rare disease. And in the US, we're expected to hear the results of approval or not, hopefully approval, by late August of 2026. So thank you for all, especially to all of the Valor trial patients, investigators, and coordinators and staff who made this study possible. And thank you for your attention. And I hope to join you potentially next year in person, if possible, and if you will have me. Thank you very much.